So I will be presenting a retrospective study on etiology and clinical profile of optic neuritis in South India. Optic neuritis is an inflammatory disease of optic nerve characterized by sudden loss of vision and pain on extraocular movements. Optic neuritis is further classified into typical and atypical forms. Typical causes include it can be present as isolated demyelination or it can be a part of multiple sclerosis. Atypical causes include neuromyelitis optica spectrum disorder, chronic relapsing inflammatory optic neuropathy, autoimmune optic neuropathy, infection, and post-vaccination. There are certain novel biomarkers associated with optic neuritis, which include aquaporin 4 IgG or anti-NMO antibody, which is against the water channels of the astrocytes, which comes under neuromyelitis optica spectrum disorder, and also myelin oligodendrocyte glycoprotein immunoglobulin, MOG IgG, which target the myelin and oligodendrocyte, that is myelin associated oligodendrocyte associated disorder. MOG IgG can also be detected in proportion of anti-NMO antibody negative patients. And what is the aim of our study? It was to determine the etiology, clinical profile, and treatment outcomes of optic neuritis patient. It was a retrospective study. We collected data from Jan 2020 to June 2021 from our electronic medical records department. All patients were subjected to complete ophthalmic examination, routine laboratory work like complete blood count, blood glucose, and chest X-ray. Neuroimaging was done for all patients. Anti-NMO and anti-MOG antibody and autoimmune profiling were done for patients who presented with recurrent or bilateral lesions or whose MRI showed demyelination. We treated all the patients with IV methylprednisolone according to ONTT trial, except for those patients whose MRIs showed features of demyelination or if the antibody test was positive. These patients received IV methylprednisolone 1 gram for 5 days, and long-term immunosuppressive treatment was initiated by the neurologist after tapering oral prednisolone slowly. We included all patients who presented with features of optic neuritis, aged 18 to 70 years. We excluded the patients lower than 18 years and 70 years, and we also excluded the glaucoma and retinal disease patient. Other causes of optic neuritis such as compression, trauma, and ischemia, patients with incomplete medical data were also excluded. These are the results we got. 124 eyes of 101 optic neuritis patients were included in the study. Mean age of presentation was 36, and 39% were male, 60% were female. Papillitis was more common than retrobulbar neuritis. 3 patients had multiple sclerosis. 4 were positive for anti-NMO, and 7 patients were positive for anti-MOG antibody. 5 patients were negative for both anti-MOG and anti-NMO antibodies. 78% had unilateral presentation and 23 had bilateral presentation. Recurrence was more common in retrobulbar neuritis patient. 45% had visual acuity of 20/200 or more during presentation. All the patients who tested positive for anti-NMO antibody and anti-MOG antibody had visual acuity of 660 or lesser. The patient who tested positive for anti-MOG antibody had a better visual outcome than anti-NMO antibody. Coming to the discussion, mean age of presentation in our study was 36 and was female preponderance, which is in concurrence with other similar studies. Bilateral involvement was seen in 23 patients in our study. 52% had papillitis, unlike in ONTT, where it was only 35%. A study by Rohit Saxena et al. Reported 53.5% of papillitis. Hence, papillitis is equally common as retrobulbar neuritis in Asian population. Recurrence was seen in 17%, which was more common in retrobulbar neuritis patient, which is also in concurrence with Rohit Saxena et al. 3 patients had multiple sclerosis in contrast to ONTT. Of that 101 patient, 4 patients were positive for anti-NMO. In a study by Pandit et al., 3 out of 59 optic neuritis patients had NMO. In our study, 7 patients tested positive for antibodies. In a similar study by R. Petabiti et al., 20 out of 95% patients tested for anti-MOG antibodies. Limitations, short follow-up period, and only those patients who presented with bilateral recurrent lesion and whose MRI showed features of demyelination were subjected for anti-MOG, anti-NMO antibody assay. We conclude that all patients with optic neuritis presenting in atypical fashion should be suspected for atypical causes such as anti-MOG antibody disease or MOG associated disorder. Even though some of the patients may be seronegative for anti-NMO and anti-MOG antibodies, MRI may be helpful to identify these atypical causes of optic neuritis. Hence, imaging must be done in all cases of optic neuritis, which may be helpful in identifying these lesions early and aid in early medical interventions. Since most of the agents used in multiple sclerosis are ineffective in treating NMO and MOG associated disorder, we should consider these antibody testing, incorporate their testing in diagnosing optic neuritis. These are my references. Thank you. If we suspect demyelination or something, we do contrast, ma'am. It's decided by radiologists.
So all patients of optic neuritis, you have to do an MRI with a contrast. You can't do a plain MRI.
Yes, ma'am.
Yeah.
You've mentioned only MRI, but you've not mentioned MRI with contrast. That is the gold standard investigation for any patient who is suspecting an optic neuritis. What are the demyelinating signs of optic neuritis on the MRI?
Ma'am, in case of multiple sclerosis, we can see the short segment involvement demyelination. And in case of
What is
NMO
the
spectrum,
classical sign?
periventricular plaques, we can see, ma'am.
So if you have a patient whose MRI has signs of demyelination, will you still want to investigate for the antibodies? MOG
No,
and
ma'am.
NMO?
After MRI only, we decided for anti-MOG antibody and anti-NMO antibody, ma'am.
Those were negative or positive, then you subjected them to antibodies. The negative cases or the positive cases?
MRI.
MRI, yeah.
Sir, MRI, if we suspect long segment involvements as in which is typical of NMOSD and MOG associated disorder, if the MRI shows pictures of NMOSD, we are sending for an.
Because in atypical cases, you have to subject the patient for the spine also, na?
Yes, sir.
So straight away, you have just subjected the patient for MRI brain and spine, or they were MRI brain?
Sir,
and
MRI spinal cord also they have.
in each and every patient.
No, sir. If we suspect demyelination disorder, sir.
Suspect.
Radiologist.
Because
Suppose if the MRI is negative and antibody is seronegative,
Yes, sir.
what treatment do you suggest?
Sir, even if the MRI is negative, sir, if the patient is having bilateral involvement, again we are giving the IV methylprednisolone for 5 days and slow tapering of steroids in contrast to ONTT trial, sir. If
If it is due to non-specific papillitis or retrobulbar neuritis
unilaterally we are following.
Did you try any retrobulbar steroids?
No, sir, we didn't try any
No, I
retro.
don't. In those days, when MRI was
Yeah.
not available, we used to give retrobulbar steroids.
yeah, decadurabolin and the dexamethasone. at that
Either
time.
retrobulbar hydrocortisone or retrobulbar dexamethasone for 1 week.
Only one thing is there, your data showed five cases which are NMO and the MOG antibody negative. Now what additional investigation you have done in those 5 cases?
Sir, we have done all the preliminary workup which includes complete blood down ESR and serum blood glucose and chest X-ray to rule out infectious etiology, sir. Then in case of recurrent and bilateral, those patients who can afford only, we subjected all the patients for those patients. We can ask we have asked the patient to go for anti-NMO. So due to financial constraints, all the patients with bilaterality we couldn't get NMO anti-NMO testing.
Only concern is that apart from infection, the collagen disease for the rheumatoid arthritis can cause a atypical optic neuritis. Okay, all these situation you have to
Like an
arthritic
condition.
condition.
AION.
Yeah.
Okay, thank you.
Thank you.